McCuistion, for over 28 years talking about things that matter with people who care. Production of McCuistion is made possible in part by individual viewers, supporters of the Foundation for Responsible Television, the University of Texas at Dallas, creating the future.
While COVID-19 has affected us all, most especially it seems the elderly and those who have immune issues, there are some groups and individuals who are more at risk than others, and there's hardly any greater risk than not having any food. Our co-host Jim Falk interviews Anurag Jain, and he's the chairman of the North Texas Food Bank, and he'll share the incredible task that they have taken on. Jim then moves on to Dr. John Carlo and Raymond Castilleja as they discuss individuals with HIV and other immune issues. But before we get to Jim's interview, I'm here with Olivia Rogers. Olivia Rogers obviously is a nurse. She's been a nurse for her whole life, and now she's the Chief Nursing Officer and Managing Director of Hospice at the Visiting Nurse Association. And we'll get a little bit more into your background, Olivia, but sure. Tell that viewer who may not have heard of the Visiting Nurse Association exactly what you folks do and how long you've been around.
So we are an older agency. We have been providing community health care for about 85 years, a little over 85 years. We have provided health care whenever and wherever it was needed at the time. So during the Great Depression, we provided care in the middle of fields in many cases for the homeless population, which was huge, of course. We provide care to people who are at the end of life right now, currently. We also provide Meals on Wheels to well over 4,000 seniors in Dallas County. So through the years, we've done a number of things, but we're very adaptable, and whatever the need is in the community at the time, that's our specialty, is to go out to the people to serve them.
All right, so I want to talk, these segments are all about people who are already at risk. And so obviously with Meals on Wheels, we've got a hunger risk there to start with. Has this COVID-19 situation changed any of that one way or the other?
It has. Actually, it's changed it enormously. And I really feel like VNA exists for such a time as this. Our whole purpose is to serve seniors where they live and to keep them in their homes. So we have found that the need for food services, as you know, has gone up tremendously. We have expanded from providing meals, as we have done for many, many years in DFW. We've expanded from that to also providing pre-packaged congregate meals to senior centers where they can drive through and pick up a meal 5 days a week. And we're providing about 3,300 of those right now, which is new for us because we can no longer do the cafeteria style meals as we usually do. We also are working with the city to provide over 1,000 meals a day to our homeless population. So we're very proud to have our kitchen still up and running safely, but to provide more meals than ever at VNA.
Thank you. I know that your background includes ICU and cardiac issues in particular. Can you tell that viewer a little bit more about, and we've heard that if you have a cardiac issue, you're more susceptible to COVID-19. So can you kind of tie those two together and then tell us what's happening there today?
Sure. So, as you know, chronic conditions set you up for a higher risk of most infections, including pneumonia. And when you have a virus such as COVID-19 that is primarily and in many ways a respiratory infection, and even though it's a virus, it is very easy right now to get a superimposed bacterial infection on top of that virus, which can lead to pneumonia. And severe enough pneumonia, of course, can lead to sepsis, which I know that a lot of people are familiar with that term, which is a widespread infection in your body that becomes very difficult to control. And sepsis and really a terrible pneumonia can lead to multi-system organ failure. So when you have someone who's already compromised, but compromised, we have to look at that differently. It doesn't mean that you're sick right now, and it doesn't mean that you are necessarily elderly, and it doesn't mean that you are already in a bad state of health. It may mean that you have an underlying illness like diabetes that is very well controlled, heart disease that is well controlled. But when you get a double whammy, being hit with such a serious virus, your overall health is seriously at risk.
All right. And so when the hospice side of things, you're trying to take care of people in many cases in their last days, maybe the last couple of weeks, or maybe it's longer than that. What is the definition of hospice in terms of time, and how has that changed in this present situation?
That's a great question. So hospice is defined as having an end of life diagnosis that if the disease runs its normal course, you would have about 6 months or less to live. And it's not a black and white situation. Your physician works with our team to decide, do they have a high likelihood maybe of passing in the next 6 months? And that's how we define hospice normally. That hasn't changed with COVID. However, we are finding and we are admitting patients with COVID because that sets them up again, like I said, for such a serious overall prognosis than they may have had with just their heart disease, or than they may have had with just COPD. You add on top of that an unknown virus, and we're seeing in many cases, you know, that they don't do well. Now, I will say on the positive side, we've admitted patients to hospice because of their COVID, and then they had some underlying issues, and they've come off our isolation list and they've recovered well. So with good care and early intervention and early testing, we are seeing that we do have recoveries. And in fact, as you know, we have more recoveries than we do deaths.
Yeah, fortunately. And you mentioned testing. Are you guys through the VNA able to do testing of these clients that you have?
We have not yet, but today we've received our first batch of tests. So we are looking forward to being able to, we've already screened, if you can believe this, we've already screened all of our Meals on Wheels clients. So over 4,000 clients, we've already done a COVID screening. We've also screened all of our hospice patients who didn't have COVID to see what their risk factors are. And if they have certain risk factors, those are the clients and patients that we're going to be testing if they haven't already been tested by their provider.
All right, we've done a couple of programs talking about mental health issues, anxiety, substance abuse, even suicide. And it's clear that one of the things that leads to those problems is isolation. And yet, if you're keeping people at home and you have people at risk already at home or in hospice, how does this affect the issue? Do they have to isolate within rooms or parts of the house, or how does that work?
So unfortunately, you're exactly right. The mental health repercussions of COVID for every age group, and even people who are well at home, you know, my family included, we've been home now for, I don't even know, 8 weeks. And it is a challenge to remain positive and upbeat. But for people who may have already been isolated, so for our Meals on Wheels clients, part of the nature of them needing a Meals on Wheels program is that they're homebound and that they probably don't have a caregiver who can provide meals for them. So the loneliness is already a problem on a normal day with our Meals on Wheels clients. What we have done and what we have seen to work is that we have now what's called virtual routes. Because we're delivering only 1 day a week to our Meals on Wheels clients, and we're giving them one hot meal at that time, and then the rest of them are shelf-stable meals so that we have less interaction just to prevent infection. We are making the days that we're not there, our wonderful thousands of volunteers that we have are making wellness checks over the phone. So we are doing basically mental health checks with our virtual routes, and that seems to really be working.
I like it. In fact, you're redefining what visiting means. And so thank you so much for all you're doing, Olivia, and thank all the people who work with you and all the volunteers. And we appreciate your taking your time to tell us about this great program and the results that you're having.
Absolutely. Thank you so much. It's my pleasure.
And now here's Jim's interview on the subject of food insecurity in North Texas.
I'm talking with Anurag Jain. He's the chairman of the board of the North Texas Food Bank. Welcome, Anurag.
Thank you, Jim. How are you?
Well, so how has demand changed at the food bank? I suspect you've seen quite a change.
Jim, it's changed unbelievably, but I want to step back and give a little bit of statistics if you're okay with it, right?
Absolutely.
So the North Texas Food Bank in our area serves 13 counties. Plano's kind of the epicenter, goes south, west, east, and west. And last year, before COVID hit, we gave out 78 million meals. And by the way, we did not fully satisfy the needs of the community. In our community, which is one of the richest in the country, there are still 1 in 6 people that are food insecure and 1 in 5 children that are food insecure. So this is before COVID. After COVID, what we saw, and by the way, to do the 78 million meals, we need 40,000 volunteers. I'll come back and tell you the problem with that. But just in the last 4 weeks, we've seen the need for food go up by 2 times. People are coming for a 7 o'clock food distribution at 4 o'clock in the morning, lining up at 4 o'clock in the morning for a $20 box of food. So you can imagine the need that's going on. We've now given out twice the amount of food we normally give out, and we're not fully satisfying the community.
Do you have enough food?
So there are some supply chain issues that are being worked out, and you hear of stories where milk and eggs and food is being wasted on one end and required at the other end because our food supply chain works with restaurants, and there's some unique things. There are a lot of people working on that problem, including the USDA, and it should get solved in the next 2 months. At this point, we have enough normal food, but you have to wonder how long this goes. So if you go 8 to 10 weeks, I think we're okay. If this goes very much longer, we have a problem.
Anurag, I'd like you to bore down a little bit more about this change in the supply chain, because restaurants, although we begin to see some opening, they've essentially been closed. And weren't they not a major provider to the food bank?
They were an absolute big provider of the food bank. They also gave us their excess capacity. But you see, when we give somebody food, today we want to give it in a contactless way. So we want to put a box together that has nutrition information, package it up neatly. Someone pulls up in a car, pops their trunk, you drop it, and they go. That way, everybody's safer than they were, right? So back that up. To make that box, we want to make sure it's nutritionally properly done, right? So each package is labeled with all the different ingredients and whatever it needs to have. On the other end, farmers and large whole-scale suppliers are used to supplying restaurants where they're giving bulk packaging. So therein breaks the supply chain, and they're going local, but the food may be in different locations. And there are some problems in transportation. So between transportation, repackaging, relabeling are some of the problems that many people are trying to solve to get it to the people that need it.
And I think one thing that people forget is how close many of our neighbors are to food insecurity. Just a day or two away if they lose their job. Elaborate on that, would you?
Yeah, I want to give some statistics. A lot of people think of a food bank as a food pantry. So I want to give you 2 data points that are very important. We use food pantries to get the food out. We really are a bank which aggregates the food, which very efficiently aggregates the food. So $1 can supply 3 meals. So a meal only costs 33 cents because of the way we aggregate it, right? So that's a very efficient way of doing it. The second statistic that people mostly misunderstand is they think food banks give food to homeless people. By the way, in our last year's statistic, only 5% of the people we gave food to were technically homeless, as in they didn't have street addresses. 95% people had homes. Now, of that, the top 10 or 15% are seniors that are stuck at home because they're diseased or something. We want to take care of our seniors, or they're kids that get a weekly meal program in school but don't get anything on the weekends, and we want to take care of those kids. But if you take out those 2 categories, 70% of the people we give food to are people that look just like you and I, that just happen to make $25,000 a year, which is not enough to feed a family. They try their best to make things happen, but if something bad happens, a car problem, 2 days of work didn't get done, a childcare problem, then they need temporary help on food because they make tough choices, and they come to us for that help.
What about with schools being closed? How did that affect the demand?
The schools being closed is a big problem. So 1 in 5 children in food insecure in North Texas is not a good statistic. It's on the lower end for the rest of the country, which means we, which are one of the richest communities in the country, are not doing a good job getting our kids fed. So we have a problem, right? The second thing is that meal program in school is extremely important. And now with kids the schools being closed, we had to put a whole program together because they have the food, they have the location, but they don't have the labor. So let me talk about how we were trying to solve that problem, if you may, Jim. Should I just?
Yeah, because you did something that's very innovative that's being copied or borrowed throughout the country.
Which is fine. So the biggest problem that schools had and food banks had is they all need volunteers and people there to get the work, get the food to whoever needs it. They have it, but they can't get it. On the other hand, we were seeing that thousands of restaurant workers and hospitality workers were being laid off. So we had a piece of technology that I had invested in. We said, why don't we bring that together? Let's take these restaurant workers and put them to work in schools and in food banks and pay them a stipend of $15 an hour. So we raised a relief fund. We were able to raise money very quickly. Our community is very generous, and put thousands of restaurant workers back to work to go to the schools, to help feed our kids, and go back to the food banks to package the food. And that's called the Get Shift Done initiative.
And you're doing that, and you started it in Dallas. Where else is it being used or applied throughout the country?
In DFW, we're doing it in 30 nonprofits. We have about 7,000 workers in the platform. We're now in 7 other cities. So this is the fastest startup I've ever done, Jim. It's unbelievable what's happening. We are in El Paso. We're in Houston. We'll be in San Antonio soon. We'll be in Northwest Arkansas and Central Arkansas. We're in Louisiana, as in New Orleans, and in Washington, D.C. And we have a whole set of cities coming right behind that.
Now, you've been involved with the food bank for a number of years. How does this crisis compare to other situations like the 2008 recession or some of the hurricanes that we've experienced in Texas?
So when you saw Hurricane Harvey, or you saw the 2008, you thought you'd seen it all. This is not the hurricane. This is unbelievable. We have never seen poverty and food insecurity change that rapidly across the country in every zip code that fast. So we went from 3.5% unemployment, and we were just beginning to see food insecurity drop, and we were celebrating that, to 31 million people that have applied for job security or for unemployment recently. So we're just seeing it go through the roof. The lines are crazy. The people that need the food are unbelievable. You talk about students in colleges, you talk about people that have good cars, but they don't have the food because the cars haven't been repossessed yet. It's incredible.
So let me interrupt. We got about another 20 seconds. What's the one thing that our viewers can do to support your work?
We need the money. I'm not going to lie to you. We earlier needed the volunteers. Right now, it's all hands on deck. The need is unbelievable. Our community's been great, but we need more money.
Keep up the good work, Anurag. Thanks for being with me.
Appreciate it.
Wow, food insecurity is huge. And here's Jim with 2 experts on other North Texans at risk for HIV and other issues.
I'm joined by Raymond Castilla. He is the Director of Behavioral Health at Prism Health, and also Dr. John Carlo. He's the CEO at Prism Health, North Texas. Welcome. It's good to be with both of you.
Thank you for having us.
So Dr. Carlo, I'd like to start off by asking you, why are HIV patients at heightened risk?
Well, it's a complex question. On the biological standpoint, we actually are seeing around the world a potential reduced risk. And in fact, the studies that are coming out of China and Europe are not finding an increased number of severe cases for people who are living with HIV. However, the challenge with that is there's more to the story, of course. And, people living with HIV have higher rates of cardiovascular disease and diabetes and other chronic medical conditions. And we know these medical conditions do place you at risk for severe coronavirus. So this is a complicated story, like most of our stories around pandemics and epidemics. And so, we're still very weary that somebody living with HIV is still at an increased risk because of the other medical conditions that they are at high risk for.
How much detail do you have on it? Can you give us a number?
Well, so in China, they looked at over 1,000 people that they knew of that were living with HIV. Now, this is a clinic setting, and almost all of them had controlled HIV virus. So they were in that well-controlled group, but they really only found about 8 of those individuals actually have coronavirus. And I believe only 1 showed any severity, and that person was in an ICU setting, but I think did fine. So really low numbers, although this is a very emerging situation, so we can't take a lot of stock in all of that because it could very well have been underreported.
Does shelter in place put more stress on people with HIV? Are you seeing more? Yeah, go ahead.
Absolutely. It puts more stress because now they're isolating. Before, they had access to come, in our clinic, come talk to a therapist whenever they needed to, because we have walk-in therapy. They had access to their social networks, to their friends. Now they're alone, isolating, now left to their own devices. And if they haven't resolved any traumatic issues that they're going through, or if they're experienced or re-traumatized by COVID because of something similar, living with HIV specifically, yeah, it's been pretty.
And I suppose that because of some of the associated health problems that people with HIV have, as you mentioned a minute ago, this interruption of treatment may be an issue.
That's right. Staying at home also, could prevent you from going out and getting medications. And of course, this is the lifeline for HIV. So yes, keeping up with all of your refills and making all those things happen during this time can be a particular challenge as well.
Are people able to come to your clinic for treatment, or are you seeing an increase in telemedicine?
Well, both. So thankfully, thanks to an incredible effort on our staff and our information technology team, we are able to do telehealth visits for routine visits, and for somebody living with HIV, there are a number of routine visits that we like to see. But we're also staying open because we know there's a lot of urgent needs that are coming up and things you just can't do over a video phone or a telephone. And so we're remaining open for those patients as well. So we're doing both, and we're trying to do as best as we can to make sure we manage everybody's needs.
Is there any problem about being able to get the prescription drugs that your patients need?
Well, not right now. And in fact, some good news out there is a lot of our health insurance plans have removed some of the refill limitations that are normally a part of HIV medications. In other words, you may only normally get a 30-day supply at a time. They've loosened those restrictions, so many people are able to get up to 90 days. So it is a little bit even actually a better convenience. But thankfully, there's not been any shortages of HIV medications at this point. Everybody, to our knowledge, has been able to get those prescriptions filled.
Is there an age issue with HIV? I read in one place that there are more people who have HIV/AIDS that are over 50. And so then they would be at greater risk.
That's right. So, another great success, I think, of the treatment and HIV treatment that we have now today, many people are living longer. And in fact, the average age for people living with HIV in the United States is now over 50. And the concern there is, of course, coronavirus illness severity does seem to trend with age. So, putting these two together, yes, there is a potential correlation with the number, people that are living with HIV and who are aging, particularly because it adds to those other conditions like cardiovascular disease and diabetes and hypertension, which do play into more risk for severe coronavirus infections.
And also, I wonder about the sense of alienation and shelter in place, because of course, some people who may be part of the gay community have a different network, may not have been accepted by their families. And I suspect, and I am asking you, does that create more anxiety?
It does create more anxiety because at their social networks, if they don't have a family support, this is their chosen family. So they're able to, this is who they get together for holidays, and they're always having dinner with or seeing, and now there's no access to them, no access to family. So it's really being creative and using Zoom, telehealth, FaceTime, just to stay connected. That's one of the things we really talk to them. It's really important to really try to stay connected in this time because they're going through the same thing as their friends.
And we've seen, all of us, these long lines now at food banks. Are HIV patients having a hard time in that area as well?
Well, we're like everyone else, these are tough times, and when job losses are happening for everybody, and so this is a particular issue, and definitely for people who are living with HIV that really, the question is, do they have an increased risk? And there's a probable there. The answer would be yes. And, the additional just concern there, it could make it harder for somebody to go access those food banks and some of those things when they know they're going to get into settings being around a lot of people and things like that.
Have you been offering any different services, special services now as a result of COVID-19?
Well, not special. We really just kind of changed our services in a sense, enhancing telehealth, making it available for our psychiatric services, for our counseling services. If we need just to do a wellness check and see people, just, was amazed when we were calling people, that was the first person that they talked to. And so they were really grateful just to have some type of connection.
Well, this is very, very important. I think you had something else to say. Go ahead.
You know, I was going to add that one of the things we're looking at right now is particularly looking at Cobra Assistants. And so, you know, health insurance, if you lose your job, you can continue health insurance through a program called Cobra. It's often very expensive, but for somebody living with HIV, we think this is a very vital thing to do. So we're looking at right now adding more programs and services and funding to support people through insurance continuation so that they can continue all the healthcare that they need.
Yeah, that's right. And I think we're going to see just in the total healthcare sort of a reorganization and reassessment. Thank you both for being with us.
Thank you.
Keep up the good work.
All right. Take care. Bye-bye.
Yes, Jim, they are doing good work. And thanks for talking with them as they shared the kind of work they're doing. As for you, our viewer, Jim and I hope that you've learned something unique about the local effects of COVID-19, and that's something that you haven't heard from other sources. We also hope you'll visit McCuistionTV.com to see other programs of interest about COVID's effects on the economy, and in particular, the oil and gas industry, because as you know, we always talk about things that matter with people who care.
For more information, call 214-750-5157 or email nickyn@nickymcquistion.com. Visit our website at www.mcquistiontv.com. You can also follow us on Twitter at www.twitter.com/McQuistionTV or download McQuistion TV video podcast on iTunes.